Thank you all for sharing your contact info in the chat. If you do have any questions for our speakers today that we don't get to during today's section, feel free to take those down if you have any follow-up questions for them. But without further ado, we can go ahead and get started. So welcome everyone to today's Legal Epi at Lunch session. Today we'll be talking about legal data for drug policy, and we have some of my colleague and some folks that we've worked with who are joining us to speak about the projects that they've led on drug policy surveillance. So really excited to have them today. My name is Alex Hess. I am the legal training manager at the Center for Public Health Law Research. I use she, her pronouns, and I'm joined today by my colleague, Jonathan Larson, who is also at the center, as well as Kate Bolton and Derek Carr from Vital Strategies. So before I let them talk a little bit more about their projects, I did want to give a quick kind of high-level overview or review for some of you maybe about what we do at the center. Specifically legal epidemiology, which is the scientific study and deployment of law as a factor in the cause, distribution, and prevention of disease and injury in a population. So really the goal of this work is to understand the role and influence of law and policy in health outcomes, health equity, and really being able to compare the variation across jurisdictions. And in order to do that, we first have to employ what's called policy surveillance, which is the systematic collection, analysis, and dissemination of laws and policies across jurisdictions or institutions, as well as over time. So this is a specific methodology that has been developed for the specific purpose of legal epi. So in order to do this work, in order to actually understand the role that law and policy play in health and health outcomes, we need the data in the first place. And oftentimes that is not readily available or accessible, or it simply just hasn't been created. And so that's the goal of a lot of this work. And so we at the center really specialize in doing just that. And so if you're interested and haven't already taken a look, you can see some of the work that we've done and our partners have done on lawatlas.org. So this is our flagship website that hosts over 125 freely available public health legal data sets. So these data sets really span across a huge number of health policy topic areas. And all of those data sets are available. The data itself is available for download in Excel CSV format, along with the codebook and research protocol. And you'll see on Law Atlas, as well as PDAPs, an interactive map and question answer set to navigate that data set. And pdaps.org is another data set hosting opioid-related policy data sets. And that is also similarly to lawatlas.org. You can navigate that in the map tool or question and answer feature on that data set as well. So they look similar, but pdaps.org is specifically focusing on opioid and drug policy. So I highly encourage you, if you're interested, to check out either of those websites and view the data sets there. And this might also be a refresher for some of you. I quickly wanted to cover the policy surveillance process itself. So we start with defining a project's scope and conducting background research. And then from there, we develop coding questions. So that's really what you see when you log on to Law Atlas or PDAPs. That question and answer set has been developed by us to capture the variables within each of the policies that we're looking to for every data set. From there, we collect the laws themselves and code them. And then finally, we publish and share that on Law Atlas or PDAPs. And for many data sets, we continue to track and update changes over time. So I definitely encourage you, if you are interested in drug policy, to check out some of the data sets that have been created using this work. A little bit about why policy surveillance is so important. For one, it helps us to create data that's suitable for use in rigorous evaluation studies. So this data supports really nuanced analysis and evaluation that is reliable and accurate and replicable. Also, it's accessible and nonpartisan information, so we're really careful to make sure that the way we are coding these laws and policies is done in an objective way. Also, like I mentioned, to be able to track change over time and measure progress. So these policies are, really depending on the policy landscape, rapidly changing over time. And so we want to be able to stay on top of that to really measure the role that they're playing in addressing specific health measures or outcomes. And so policy surveillance allows us to do that. Also, for diffusion of innovative policy ideas, we can also use this work to track where new or novel things are being done at a state or local level. And finally, building workforce capacity. So part of this work that we do is also teaching others how to do policy surveillance for policy areas that they're interested in as well. So if you haven't already, I'll plug our Introduction to Policy Surveillance webinar where you can learn more about the policy surveillance process itself. But today we're really focusing on legal epi and its use for drug policy and why it's so important. And so you'll be hearing from that from our speakers today. So much of drug policy, as I'm sure many of you know, regulated at the state level, where there is often significant variation in how states have responded, or in many cases have failed to respond to the ongoing opioid overdose epidemic. And so just to name a few policy areas that, and many of these you'll find on PDAP's licensure, drug criminalization or decriminalization, things like Good Samaritan laws, which provide a certain degree of immunity for people who call 911 in the event of an overdose. The reason for these laws was because there's a lot of fear in calling for help because of the possibility of being arrested for possession of drug or paraphernalia. So there's a lot of work that we've done and colleagues have done in tracking Good Samaritan laws, but also identifying and shedding light on the fact that even though these laws exist, there's a significant gap in how they're enforced. And so that's just one example of the value of doing this work, to also understand where the law is coming up short and being able to adequately respond to the needs of people who use drugs. Also, access to naloxone, which is a life-saving drug that can reverse an overdose, and as well as access to medications and treatment for opioid use disorder. So you'll be hearing a little bit more about that from our speakers today. Other things like prescription drug monitoring, syringe service programs, and many others. So these are just a few examples of the ways in which states have discretion to regulate drug policy. And we'll be hearing today from our speakers specifically about the comprehensiveness of state policy to prevent overdose deaths, as well as buprenorphine prescribing requirements and limitations. So without further ado, I'll introduce our speakers to you today. We'll be starting with John Larson, who is a legal program manager at Temple University's Beasley School of Law Center for Public Health Law Research. His research focuses on drug policy and access to healthcare. And prior to working at the center, John spent several years as a health policy consultant, providing federal and state legislative and regulatory analysis for biopharma clients. He has broad health policy experience, particularly in oncology, having served in policy roles at the American Society of Clinical Oncology and at the National Comprehensive Cancer Network, where he also managed international business development. John holds his JD from Temple University's Beasley School of Law, and MPP from George Mason University's Schar School of Policy and Government, where he was a Bryce Harlow Foundation Fellow and a BA from Tufts University. Kate Bolton is a legal and public health professional and is currently senior legal technical advisor to the overdose prevention program at Vital Strategies. She focuses on drug policy, overdose, harm reduction, and strategies to promote the rights and health of people who use drugs. Prior to joining Vital Strategies, Kate worked as staff attorney at the Center for HIV Law and Policy. She served with the Center for Disease Control and Prevention from 2007 to 2012 in the Division of Global Migration and Quarantine. Kate earned her JD from Harvard Law School and her MPH from the University of Michigan. Derek Carr is a public health attorney who currently serves as legal technical advisor for the Vital Strategies Overdose Prevention Program. In this role, Derek supports local, state, and federal initiatives to advance public health and harm reduction approaches to substance use and overdose. Derek was previously a senior attorney at ChangeLab Solutions and a legal fellow at the Network for Public Health Law. He earned both his BA and JD from the University of North Carolina, Chapel Hill. So thank you so much to our three speakers today. And again, if you have any questions for them, please feel free to use the chat or Q&A. They may be able to get to them as they're speaking, but we'll definitely have time at the end to answer questions. So John, I will pass it over to you. And if you'd just like to tell me when to advance the slides, just let me know.
Awesome. Thank you so much for that excellent introduction, Alex. And I'm very happy to be here with Kate and Derek today to talk about these important issues in drug policy and how we can be leveraging policy surveillance as a tool to really promote change in this space. We have at the center been working with Nick Terry and Indiana University on a grant from the Foundation for Opioid Response Efforts to really look at the whole of government approach and how we can be better addressing the current overdose epidemic. The data is consistently bad. We see that deaths are increasing, and we are using this project to take a look at what policies can really be implemented to help make some change right away. Next slide, please. So in that effort, we have acknowledged that we have more than 20 years of unacceptable opioid overdose deaths, and government is still not pulling together as it should. Coordination is lacking both horizontally and vertically. So horizontally across levels of government, whether that's across federal agencies or across state agencies or across different local government entities. We looked at how these relationships have kind of sometimes hindered opioid response, how the laws across jurisdictions may interfere with that response, and how we also acknowledge that the existing structure in place really is a pre-existing whole of government response, which has failed, which is the war on drugs. So how do we look at this this complex area of law across all these jurisdictions to try to find some solutions to the problem? We start with this pyramid to just explain what's happening. I'm going to drop in the chat here the details of all the white papers that we have produced on this topic that get into greater detail. But next slide, please, Alex. So we're all aware that the rates of opioid-related overdose death have been increasing, and clearly what is happening in response to the crisis has not worked. Next slide, please. So our team looked at trying to come up with a transformational model that goes beyond the traditional drug policy pillars and looks at really finding a way to get past the war on drugs. So removing the drug war impediments to treatment, accepting that harmful substance use is a chronic condition requiring redesigning healthcare, remedying the root causes of opioid use disorder, looking at some of those issues, whether it's housing or unemployment or the incarceration system. There are many many policy solutions and legal actions that can be taken that we wanted to delve into with this project. Also looking at how we can build better harm reduction systems and to reduce the interference from contrary laws like drug paraphernalia laws that might make different local jurisdictions uncomfortable with operating, say, a certain service program as an example of those kind of existing barriers between levels of government. And then just reimagining how funding can flow better between levels of government to really focus attention on the issues at hand. Next slide, please, Alex. So in the course of the project, we really delved into the evidence that exists. We looked at a number of domains specifically to address these existing problems. So we looked at drug policing. The next slide, please. We looked at the healthcare domain. We looked at harm reduction. And we really looked at the society and whole person aspect and looking at social determinants of health and how those could be addressed. Next slide, please. So we came up with 84 legal opportunities to address all of these domains, things that can be actions that can be taken now to improve alignment, improve coordination at the federal, state, and local levels, and across different agencies, departments, administrations, and amongst practitioners to really find some solutions to move forward past the war on drug mentality, which is so focused on criminalization. Alex had mentioned previously Good Samaritan laws. Well, when we have Good Samaritan laws that are trying to, are actually responding to the criminalization and the fear of retribution for people who use drugs, then the Good Samaritan laws are then interplaying with drug-induced homicide laws that could create additional layers of fear and kind of negates the intended effects of some of those interventions. So next slide, please. One of the tools that we produced through this project was a searchable database that takes all those 84 opportunities across those domains and allows you to sort them and to start trying to make sense of what needs to happen to make change. So this is a very straightforward example around overdose prevention centers. The number one issue that has prevented overdose prevention centers from really having broader pickup outside of the authorized OPC in Rhode Island, and now there's an authorized OPC being developed in Minnesota, has been the crack house statute at the federal level. So that has really been a barrier to change. So if the federal government could remove the crack house statute and remove that barrier, that would be a boon at the state and local levels. States can enact legislation that permit OPCs, similar to what Rhode Island did, and in Minnesota this past year. Municipalities can use local health authority to authorize the use of OPCs, like what was done in New York City, to really provide these safer spaces that will help with harm reduction. So next slide, please. So that was a example of just one area within very concentric OPC specific. You could look up any topic, MOUD, treatment by secondary domain in that database. So it has some practical use. I encourage you to play with the tool and see what you can find and see if these make sense to you. they are all cited with evidence base, and they all link back to those white papers that go into much greater detail. But you see here local opportunities, some of which are, just we're thinking about cities, we're thinking about counties having to operationalize some of these programs where they have other levels of government that might be hindering their operations. One area would be buprenorphine and naloxone stocking. The city of Philadelphia has a mandate for pharmacies to stock naloxone. So that's one example that could potentially be picked up by other jurisdictions. There's also different examples here at the state level, which we already covered around OPCs, different federal opportunities like different payer structures, looking at potentially having a Ryan White HIV/AIDS type program that would expand health insurance access to OUD care. Just looking at all of the different levers that exist in the system. So please explore that tool. We're very proud of that work. Next slide, please. The other piece of this project, as you can tell from the original title on the first slide, is looking at the comprehensiveness of opioid response, and we're using policy surveillance to create data sets. We had an expert advisory committee that helped us to identify some areas of focus for this. We're creating 10 data sets in the course of this project. We have 4 published, and you can expect more by May 1st. Here's an example in the healthcare space, looking at Medicaid expansion and Section 1115 waivers. This is just an example of states that have passed or that have submitted to CMS and have approved Section 1115 waivers that would address housing support. So that taking a look at all the underlying issues that might be preventing folks from getting OUD care. Next slide, please. We also published a data set on incarceration effects on Medicaid status. This is just an example of statutes and regulations that are requiring suspension of Medicaid rather than termination. When folks are incarcerated, they lose their Medicaid coverage. The state has an option to either suspend or terminate that coverage. And once folks are returning to the community, if the state has suspended the coverage, it tends to be somewhat easier to get back and continue existing OUD treatment if it hasn't been terminated. So this is a good example of just at the state level actions that have been taken to promote that coordinated return to the community and make sure that access to care continues, because it is so dangerous for that population. Overdose deaths are much higher when returning to the community, and making sure that there's access to care, mental health treatment, et cetera, are all things that can happen through Medicaid 1115 waivers. So please check out that data set. Next slide, please. This is an example of there's been massive uptake in Good Samaritan laws. There's tremendous variation within those laws. So if you take a look at that data set, you can see where there are a couple states that still don't have Good Samaritan drug overdose laws in place, but you can see the variation by looking through those variables. 48 jurisdictions and the District of Columbia currently have Good Samaritan laws. Next slide, please. And then the example of drug decriminalization, and the fact that there's one jurisdiction that actually has decriminalized a personal possession of controlled substances. Obviously, that's under threat now in the current session in Oregon. but this data set was created as kind of a baseline to hopefully track additional states that made this decision to decriminalize personal possession, so that there could be some comparison. But all of these put together, these 10 data sets, we're also looking at drug paraphernalia, that laws, and how fentanyl test strips have been legalized under those laws. As one other area, I mentioned drug-induced homicide laws. We're going to look at deflection laws, how the opioid settlement funds. We have an existing data set that we're updating through this grant on the opioid litigation settlement funds, and how those are structured, how the trusts are structured across the states. So that already exists, and then we're going to kind of coalesce the variables from all of those data sets to provide a sense of where states have taken action, and where states have opportunities to take action in the future. So that's a good example of how policy surveillance can be used. And I'm really looking forward to Kate and Derek's presentation on buprenorphine, and just taking questions from the group. But thank you for listening to this presentation, and I'm really excited about the work. So without further ado, I turn it back over to Alex, who will turn it back over to Kate and Derek.
Thank you so much, John, for sharing more about this really important project. I don't see any questions, so we'll keep it moving on over to Kate and Derek with vital strategies.
Thanks, there. We really appreciate the opportunity to join today and share a little bit more about a new legal data set that we developed in close partnership with the Center for Public Health Law Research around state level statutes and regulations on prescribing buprenorphine for opioid use disorder. And before I jump into it, I do have to give the usual disclaimer of, while Kate and I are lawyers, we are not your lawyers. And so all of this is just for informational purposes and is not legal advice. Next slide. We already introduced ourselves, so I won't do that again. Next slide. Just as ways, a little bit of background. So Vital Strategies is a global public health organization that believes that every person should be protected by a strong public health system. Most of the organization's work is focused international, but the overdose prevention program, where Kate and I sit, is the organization's only domestic program, and we are the lead implementation partner for state-focused work in the Bloomberg Overdose Prevention Initiative. So leading implementation work alongside with partners in evaluation at Johns Hopkins, CDC Foundation, and Pew Charitable Trust. And we bring a comprehensive approach to equitably and sustainably reduce overdose deaths, really focused in 7 states, Kentucky, Michigan, New Jersey, New Mexico, North Carolina, Pennsylvania, and Wisconsin, but also do some national work as well, work that has implications for all states, like this project that we're about to discuss now, and also do some work at the federal level as well. Next slide. So for the next few minutes, we're just going to briefly set the context for talking about the new buprenorphine laws data set, talk about some of the key findings from that research, and then briefly talk about some next steps and opportunities for leveraging the new data, both for research and implementation advocacy purposes. Next slide. So before jumping into the main focus of today's presentation on state laws, I do want to provide a very brief history of the federal regulatory framework for treating opioid use disorder and medications for opioid use disorder, because it really set the foundation for what we see at the state level today. So, if you want to go really far back, we can go back, to the early 1900s, where the Harrison Narcotics Tax Act was enacted and really outlawed the use of controlled substances to treat addiction and conditions like opioid use disorder. And that was really the law of the land up until the 70s, where you got the Controlled Substances Act and Narcotic Addict Treatment Act. And I'll note on language choices there, these are not words that we would use to describe these things, but for fidelity to what the names of the laws are or how they're discussed, using those otherwise stigmatizing terms. So after those laws were passed in the early to mid 1970s, really the only way of accessing medication treatment for opioid use disorder was through a highly regulated opioid treatment program. So having to go every day or almost every day to get your medication, and at that point being largely exclusively with methadone. In 2000, Congress acted to pass the Drug Addiction Treatment Act of 2000, and this is the law that established what was formerly referred to as the X waiver. So this was a separate registration that physicians could get that would allow them to prescribe Schedule 3 or below medications like buprenorphine outside of opioid treatment programs. And that was followed by the approval of buprenorphine for OUD in 2002. There was a very incremental expansion of who was eligible for X waivers, extending it to nurse practitioners and physician assistants and similar mid-level practitioners between 2016 and 2018. And then finally, sort of the elimination of the X waiver entirely in December of 2022, which is where we are now. There are no additional federal requirements that apply to be able to prescribe buprenorphine for OUD besides sort of the general rules that apply to controlled substances. Next slide. So the data set that is the main focus today, as I mentioned, is a comprehensive data set of state-level statutes and regulations that specifically apply to prescribing buprenorphine for opioid use disorder. And it's current as of March 1st of last year, but we are planning to update it to bring to capture more recent changes to state statutes and regulations as states continue to implement the federal removal of the X waiver. I do also want to briefly note what the data set does not capture, right? Like there are hundreds and hundreds of types of laws that have some indirect bearing on prescribing of buprenorphine, but we weren't really interested in sort of those generally applicable controlled substance laws, scope of practice laws that generally relate to, whether a nurse practitioner can prescribe controlled substances at all. The prescribing of buprenorphine for conditions other than OUD, like pain, laws that apply specifically within OTPs, or sub-regulatory policies like Medicaid state plans or private insurer policies. And we also excluded laws that were specific to state Medicaid programs. And I do want to note there that exclusion was not a reflection of the lack of importance. To the contrary, Medicaid pays for an overwhelming percentage of substance use treatment, including buprenorphine treatment. And so it's actually a really important area to study, but because so much of Medicaid policy is not codified, it's in the sub-regulatory materials, managed care contracts, Medicaid agency guidance, billing manuals and the such. Just capturing the codified requirements would really give an incomplete picture of the landscape of Medicaid restrictions. And so its exclusion here is not a reflection of the importance, but just rather a reflection of that you really need to apply a different research methodology in order to capture that information. Next slide. So why examine state laws on buprenorphine prescribing for OUD? There is an increasing recognition of the need for low barrier access to SUD treatment broadly and buprenorphine access specifically, and the recognition of the need to address regulatory impediments to low barrier treatment. So, we can see from SAMHSA recent guidance that they've put out about the need to address regulatory policies, but we also know that efforts to address legal barriers to expanded buprenorphine access have focused primarily at the federal level, like eliminating the X waiver that was successfully done a couple of years ago. But we also know that the benefits of that sort of federal deregulation and expansion of care won't be realized if restrictive state laws remain in place. But there was no comprehensive public data set of those state laws. So we were really pulling from multiple sources, trying to scrap together what the landscape looked like, and really saw that as a gap in the field, both just from a general understanding standpoint for patients, for providers, but also for the ability to conduct research on what the actual effects on treatment access and quality and outcomes are from these different regulatory schemes. Next slide. So just a sort of broad strokes overview of what the data set found. We found that at least 19 states and the District of Columbia had laws explicitly regulating buprenorphine prescribing for opioid use disorders, and those varied pretty significantly in the scope of their application. So in 7 states, they applied to any and all practitioners that have the legal authority to prescribe buprenorphine. In 3 states, they applied to particular types of practitioners. So there might be a regulation that applies to APRNs or physician assistants, but not to physicians. 2 states had laws that applied only when a practitioner treated more than a specified number of patients. So similar to how the X waiver formerly had patient limits, it might be there are no additional regulations if you're treating up to 50 patients, but once you're treating more than 50 patients, this additional layer of regulation comes into place. And then 11 states in DC applied the regulations in certain types of practice settings. So that could be places like New York and New Jersey and Massachusetts, where the laws only applied in the context of state licensed SUD treatment programs and not in sort of your traditional like primary care treatment settings. Or they only apply to the provision of telehealth, which we capture as a practice setting, or only applied in certain types of facilities that either treated more than a certain number or percentage of patients, or met other criteria like they directly dispense buprenorphine. And then also that 15 states as of this data set continue to incorporate outdated provisions of federal law related to the X waiver. So a real disconnection between the federal legal landscape and the state legal landscape, and exactly how that looked in each state varied a lot, but certainly there were a number of those states where sort of eligibility to prescribe buprenorphine was still conditioned on obtaining an X waiver, so raising questions around the ability of new practitioners coming into the space being able to prescribe for OUD. And with that, I will hand it over to my colleague Kate.
Thank you, Derek. So I'll spend the next few minutes just talking a bit about our findings with this project in a bit more detail. So, the many dimensions of state regulation of buprenorphine prescribing and what that looks like. So in this project, we identified a number of domains that you see here. So, states stipulating in a pretty prescriptive way the components of an initial evaluation when someone is starting buprenorphine treatment. We saw a number of states with counseling requirements. So this could be just a generally stated requirement that counseling occur in tandem with buprenorphine, or it could be more elaborate. So the content or format of the counseling, the frequency of the counseling. We saw requirements around drug testing. So again, it being mandatory, but also states stipulating a particular frequency. Ditto on visit frequency. Some states speak to the length of a prescription for buprenorphine or impose constraints on the formulations of buprenorphine used or ceilings on dosage, whether at initiation or maintenance or throughout the sort of life of someone's treatment experience. We were especially interested in how states defined and outlined particular responses to, quote, patient noncompliance. This is sort of the catch-all language that we used. It's not a terminology that we use within our program, but really trying to parse the types of behaviors classified as noncompliance warranting some kind of response by the clinician. We looked at whether states addressed treatment for special populations with buprenorphine, for instance, people who are pregnant or who can become pregnant, and ancillary services. Some states require referral to specific kinds of outside services. This is beyond counseling. So this was relatively diverse. And lastly, a small number of states sort of expressly state a requirement to taper, sort of commitment to taper off of buprenorphine as a medication. Next slide, please. So here's just a bit more detail on the magnitude of these requirements in the states that we looked at. So 14 states in DC mandated counseling for some or all buprenorphine patients. 4 states established a minimum frequency of counseling services. So I had made a note about Utah, which is a state that has a kind of tiered scheme, counseling once a week for the first 90 days of treatment, then a 2 times monthly phase, I think for 6 months, and then once a month until discharge from treatment. So a counseling requirement that applies throughout someone's treatment with buprenorphine. 8 states regulated dosage, whether at initiation, maintenance, or both. 5 states restrict dosage without exception. So, for instance, in Ohio, you can never exceed a dose of 24 milligrams of buprenorphine, whatever the circumstances. 17 states in DC, so this is much of the total cohort of states with these laws and regulations around buprenorphine prescribing, a required drug testing, 8 states with a specific frequency of drug testing, and finally 8 states in DC. Thank you, Derek, for putting that in the chat. Yeah, folks can be kind of exploring this data set as we're talking about it. 8 states in DC have visit frequency requirements. So how often is someone seeing their clinician as they're receiving buprenorphine treatment for OUD? And 5 of these states and DC impose these requirements for the entire duration of someone's treatment. And you see here on the left, this is a quote from a recent paper that I worked on along with some colleagues from Vital Strategies and Johns Hopkins University. But really, it's about the need for state policies to minimize high threshold practices that reduce patient retention and care and thereby undermine an effective response to the overdose crisis. And part of why we made that recommendation and reached that conclusion was in the paper, we looked at the impact of mandated counseling and drug testing at every visit when someone's receiving buprenorphine treatment. And we saw that prescribers who were drug testing at every visit, patients were 38% more likely to terminate treatment. Where there was mandated counseling, it was 33% more likely to terminate treatment than those who did not require counseling. This is clinician self-report, I should say. But the point is, we see a very tangible impact of these high threshold practices, some of which are required by regulation in state law, are associated with people getting booted out of care. Next slide, please. So here you see what we found in terms of non-compliance. So the types of non-compliance that states outlined, and then permitted or mandatory responses to that non-compliance. We've organized them here by frequency. So drug screening results, whether that was evidence of continuing illicit drug use or return to use, or the prescribed medication not showing up in those results, all fit within this sort of umbrella of drug screening. We saw refusal or inadequate engagement in counseling or other kinds of services, and diversion. So these are all specifically named, and the parentheses is the number of states, if that wasn't clear. In terms of other, this is kind of a mixed bag. Just looking a few minutes ago for an example to share here, in West Virginia, repeated loitering is an example of one of these kind of general types of non-compliance that can be met with sanctions or discharge. So those are important to be mindful of, especially where they're quite permissive and can encompass lots of different kinds of behavior. And then in terms of permitted or required responses to these different types of non-compliance, we saw requirements to kind of reassess the plan or document the non-compliance. We saw among 4 states the need for a referral to some kind of more specialized or higher level care. In a few states, we saw protective provisions. So you see here prohibition on involuntary discharge, discouraging involuntary discharge, and a prohibition on dosage reductions in one state. And again, you have another category that encompasses a diverse range of responses. So I noted a downward dose adjustment as a requirement, or implementing a plan with a patient to optimize medication adherence. So that's something quite general, could look very different from clinician to clinician. Also want to note that this is not a one-to-one relationship. So these types of responses are not required for every single type of non-compliance in a state scheme necessarily. So a state might have, a kind of mix and match approach. So just important to understand that you actually have to examine how a state outlines the specific type of non-compliance and then some kind of specific response. Next slide, please. So I mentioned just now that some states have more protective measures, which is exciting to see and consistent with, the overall trend that we're seeing towards low barrier care with SAMHSA's advisory. Also, with, for instance, the new OTP regulations from earlier this month, you see a patient's refusal to engage with counseling, that can't be a basis for denying care. So there are different ways in which we see this showing up in an increasing movement towards this approach, but just a few specific examples to outline. We have in Massachusetts the requirement that drug screening results not be used to expel someone from treatment, but should be instead an aid for treatment decisions. In Vermont, you have this prohibition on discharge when someone doesn't want to engage or participate in counseling or other ancillary services. The prohibition on dosage reduction, which I think I mentioned in the previous slide. So that being based on some kind of clinical judgment, clinical documentation, not punishment. Lastly, we see a couple states requiring provision of naloxone as part of buprenorphine treatment. Where we go from here, we want you and other stakeholders to use this data to examine the impact of restrictive or protective regulatory schemes and how that affects treatment access and outcomes. And of course, more awareness and engagement around the legal landscape on this issue in different states, because there are clearly advocacy opportunities and opportunities for reform, and opportunities for direct advocacy and participation in that process. Next slide. And I think I'll leave it at that. Thanks.
Thank you so much, Derek and Kate. Sorry about the end there. I started clicking on the fast forward and then I got lost. So thank you so much to all three of our speakers today. I'll leave their contact information up for another moment or two if you'd like to take that down. I believe our speakers also left their contact info in the chat if you want to take a look there as well. Any questions about either of these projects, any of the work that they've done? Thank you all again so much. Also sharing my contact info and our social media handles for the center as well. And again, here are our websites. Law Atlas and pdaps.org, again, are where you can find the data sets that have been created using policy surveillance. And I think, Derek, thank you so much, also shared that in the chat as well, the direct links to their project. All right. And I'm not seeing any questions, but I did have one for you all at Vital Strategies. I know that you mentioned, Derek, that this particular research didn't include Medicaid policy specifically, especially just because it would require such a different research methodology. So I was curious if you could speak, if any of you really, because I know, John, Medicaid waivers are also something that you've looked at in your research as well. What you foresee as kind of the importance of doing policy surveillance specifically for this work, or what are those challenges, whether that just be even like practical or logistical, because as we know, I think Medicaid is such a big component of access to treatment and healthcare. So I don't know if anyone wants to answer that question, I'll let you all have at it.
Yeah, and welcome to other thoughts as well. I think the super important. I don't think it's necessarily harder. It's just a different methodology. One challenge would be statutes and regulations, right? Like where to go for them. They're all in one centralized place for every state, as opposed to Medicaid policies that are not centrally located anywhere. They might not be publicly accessible online at all. So it oftentimes requires filing Freedom of Information Act or whatever the state level equivalent of public records laws are to get those documents, whether that's agency guidance or managed care contracts. And so really sort of the once you gather the data, it's a very similar process, in terms of capturing the varying characteristics of the policies, but that initial stage of sort of collecting all of the documents of where that information would be just requires a little bit more legwork.
Yeah, Derek, I don't know if you remember how we worked together on an initial diabetes project where we were looking at statutes, and it's never the complete picture, right? Because of sub-regulatory policy. And when you really get into it, the whole project design needs to change around, well, do I need to do a survey of Medicaid directors to get some of these documents? Because we know, longitudinally speaking, you're going to have a really hard time building the historical record back. if you don't know exactly what's going on. And to get that, even to get the scope of what is the universe is really difficult. Like when we're doing our traditional legal research, we can have some faith, right, in the existing statute being the complete picture. But all of the points you made, Derek, about the importance of the Medicaid policies is extremely valid. One of the things that was difficult in our incarceration effects of Medicaid status project was we essentially had to stay at a state statute and regulatory level, knowing that there's so much that is happening in the Department of Corrections that might just be on a piece of paper and never made public in any tangible way. So those are going to be gaps, but I do emphasize that the value of the things that we can study, providing the level of detail to see from this buprenorphine project was really great to see, because every single time you have one of those counseling requirements, you have some other thing that's going to affect patient access. It's really important to understand that. It's like, is there ever a need that we need that counseling? Like, how can we minimize change policy to get the best effects possible? And this is how we do it. That's why policy surveillance is so incredibly important. So it gets me revved up, and I appreciate you all bringing up your work, because I've been looking a lot at buprenorphine and just transitions into the community, and you have to start with the coverage, right? If you don't have coverage, or if there's a $1 copay, there's a $2 copay. So like you have this difference, and well, I'm not gonna bother. You know, I can't do it. I can't afford that. So I'll leave it at that. I know that was a pretty lengthy response, but I get jazzed up about this.
Thank you both, and to Kate also for sharing that link in the chat to the paper. I think there's maybe time for one more last question. If anyone would like to respond in the chat, can you speak about the amount of time and types of methodological skills one realistically needs to do this work? Which is a great question. For example, if writing a grant, is it appropriate to wrap this into a research aim, or does it constitute its own aim because it's so time intensive? I don't know if anybody would like to speak to that really briefly before we hop off, but I think that is a very good question.
This is a really good question. I mean, there are so many things to try to figure out about scoping a project. I think it's at that level of the question. You know, generically speaking, how do we address policy surveillance, and just knowing what questions you want to ask of the law is going to answer so much more of what we're going to do. Just like we were talking about, okay, it is really time intensive to like have to build in a survey of Medicaid directors, and then it's going to be a different, you know, you change the scope in that way. But if you know you're going to be using Westlaw, LexisNexis as an example, you know what those costs are, and you can build out what that legal research is going to look like. And then, you know, we have all of the redundancy built in. Alex was talking about the process using scientific method. It's just so valuable to have that, so we can replicate this kind of work. So if others wanted to get into it, you know, five years down the line, if the funding stream hadn't continued, you know, you can pick it up and really, you could build out the longitudinal data set. I hope that answers the question. I was speaking kind of generally.
Yeah, I mean, just to add, I mean, as a grant making program, I would say this type of project is relatively specialized, and I think it's great that there's an increasing sort of interest of policy surveillance and increasing number of people who are getting this kind of specialization. But it's not like something we would just tack on to a project or a grant because it's an area of interest. it to reflect that level of robustness, methodologically, the redundancy, et cetera. So I do think it's a growing field, but also important to recognize what it all entails and the great work that you all do. So thanks.
Thank you both for that. I'll also add that I don't think legal expertise or being a lawyer is ever a necessary part of doing this work, but sometimes having a lawyer, even as a subject matter expert or somebody who has policy expertise of whatever legal landscape you're doing this work on, can be really helpful to navigate just that sort of structure. So that is also maybe one of the practical considerations, but definitely folks who are not lawyers or don't have formal legal training can certainly do this work as well. So I think that's all the questions, and I know we're out of time, so thank you so much to everyone for joining us today. I will be sure that you get this recording in a follow-up email, and thank you again so much to John, Derek, and Kate for joining us to speak about these really important projects. So applause to you all, and thank you so much, everyone. Have a good rest of your day.